Welcome to our podcast, Psychiatric Services, From Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Good morning.
Good morning. It's beautiful out here.
It is beautiful. It is Memorial Day weekend. We are inside on a gorgeous day recording this.
Happily.
Yes. Life is great. So today we're going to talk about 4 articles from the journal. So we're changing it up. We're just full of surprises that have recently been published online. We're going to take an inside look at an article about an innovative program to engage early psychosis patients from hospital. We're going to cover 2 essays about legalization of cannabis. And finally, we're going to cover an article that focuses on the aftermath of celebrity suicide. So let's get started.
First up, we have Daniel Anderson and colleagues on NYC START, a new model for securing community services for individuals hospitalized for first episode psychosis.
Hey, NYC stands for New York City, doesn't it?
It does stand for New York City, so this is a home team article, and it's first episode psychosis, so this is like...
Well, it's something that interests me.
Yes, definitely. Mm-hmm. And so you were actually around and doing a lot of research on first episode psychosis in kind of the early 2010s. And it was really becoming clear that early intervention was helpful for people with first episode psychosis.
Right. Yeah. So, we actually started with the RAISE study in 2008, 2009. And the importance of engaging young people with first episode psychosis and having as short as possible a duration of untreated psychosis was really in the air. People were understanding this, and there was this very exciting, promising new approach to treatment, which we now call coordinated specialty care. But we're talking about back in, say, 2012, 2013, and the city and the leadership of mental health in New York City was really focused also on trying to contribute and helping with this problem. And they thought a lot about, well, what happens to young people who are hospitalized with first episode psychosis? What happens to them after they're hospitalized? And they looked at the data. Well, they actually had an idea, which became NYC START. But in sort of thinking through NYC START, they looked at previous data and they found that in 2011, of people hospitalized for the first time with schizophrenia or psychotic disorders, only 59% attended an outpatient follow-up appointment within 30 days, meaning that over 40% did not. And you're talking about young people for whom ongoing treatment is really important, who had a very serious new disorder. So that was a problem.
So this is an issue where we've started to identify an intervention and we've identified a big service gap. And then this program that they created is trying to kind of bridge that gap.
Close the gap
between the two.
Right.
So here's what New York City did. First, they created a way to identify people with first episode psychosis, and then they created a program to link them to services. And that finding part, which I think we'll talk about a little bit later in a little more detail, in 2014, the health code in New York City was actually amended to create a reporting requirement that when someone between the ages of 18 and 30 was psychiatrically hospitalized for the first time, they had to report it to the Department of Mental Health and Mental Hygiene in New York City.
So just think about this. So a person's hospitalized for the first time, and the hospital is obligated essentially to call the health department, DOHMH, and say, we have a first episode of patient here.
And so what does the Department of Health and Mental Hygiene do with that information? So they created this program called NYC START. It stands for Supportive Transition and Recovery Teams. The teams are made up of social workers who each carry about 12 clients and peers who work with a number of social workers at a time and carry a caseload of more like 24 to 36 clients. So the idea is that the Department of Health and Mental Hygiene has the name of a person, and the team will reach out to that person to offer this program that's basically 3 months of critical time intervention, which I think or hope we've talked about before, but critical time intervention is an evidence-based intensive care coordination model. And teams are really engaging people in getting to psychiatric and medical appointments. They offer family support, peer services, help with housing, education, employment.
Yeah, and I think, so the key points here are that this team, which for each individual client, potential client, would consist of a social worker and a peer who go into the hospital and try to engage that person who's been identified in this service, and the service is offering help and assistance in the 3 months, 4 months after discharge to help them get into services and provide other assistance that they need.
The idea is to transition them into sort of stable care, but it really is an intensive intervention. They're really looking at the whole person and the family system and offering a lot of different services to get them into more stable services after the intervention is over.
Yeah, and I think just then the context for this is that at the same time, New York State Office of Mental Health is providing an increasing number of slots for On Track New York, which is the ongoing coordinated specialty care program for young adults who have early psychosis in the state. So
they have somewhere to send them to.
Right. But again, all be driven by preference of the client, et cetera, et cetera. But On Track New York is now sort of in the community, and NYC START and On Track New York teams worked closely together.
So here's what the study's about. Everything I mentioned was kind of in the study or the intervention design. And the basic idea is that they're seeing how their design is working, whether or not that's working. So they're trying to understand a little bit more about the demographics, rates of enrollment, how long people stay in the program. It's designed for 3 months, how often people are contacted, and then also whether or not the clients actually connect with the services. So they looked at the 404 people in 2016 who were reported to the Department of Health and Mental Hygiene as having been hospitalized with first episode psychosis, who were deemed eligible to participate in the program, and who were actually approached to offer the program. So 71% of them agreed to participate in NYC START services, which is pretty good for a difficult to engage population.
Yeah, and I think we could argue it's good. We could argue it could be better. But I think this is a benchmark, this is a new program, and this is what it was in 2016, so 71%.
And just to give you a sense of the demographics, about 2/3 of those who agreed to participate were male, about half were African American, 60% were on Medicaid, and the demographics of the people who said no to getting the intervention, to getting NYC START services, wasn't significantly different from that. So of the people who enrolled, 78% stayed with the program for the full 3 months, and only 7% were lost to follow-up. So we talked a lot about the contacts that people get and how often they're happening, both in the beginning and the end. So in the first weeks of enrollment, clients receive an average of 2.5 contacts per week, and those were mostly face-to-face. And as they expected, as time went on, the contacts tended to be through other means, phone, text, other ways of getting in touch. And then in terms of linkages to outpatient mental health, 87% attended a mental health appointment, and 78% of those did that within 30 days of discharge.
Yeah, so if you think about what the overall rate of having a mental health appointment was in the administrative data sample from 2011, it was 59%, and so this increased substantially higher percentage of people getting into care, although again, it's not the exact same population.
Right, and it's not a control group that they're comparing it to.
Right.
But nonetheless, it's an important program and an important study because this is really innovative stuff.
Yeah, and I think that this was a really complicated and somewhat controversial change to the public health code, because I think many people in the psychiatric community and many hospital staff worried that this was going to violate the privacy and the confidentiality of people and risk exposing people, putting them on some kind of list.
A registry
for having what is, an extremely stigmatizing disorder. And it was hard for some people to see that this was, in some sense, a public health move to try to make sure that people who had potentially very disabling illnesses for whom there was evidence that earlier treatment, could help and even improve long-term outcome, that was the motivation behind this, and that there were many protections built into this process so that there would be very little, if any, risk of inadvertent disclosure. So if a person said no, their name wasn't maintained on any kind of list or registry. In fact, this wasn't a registry.
It was identification and
exactly
contact.
Right.
I mean, I think it's really interesting that on one hand you have valid privacy concerns and worry about particularly the stigmatization. Mm-hmm. On the other hand, you've got a public health approach that is sort of like, why is first episode psychosis any different than tuberculosis? Why would we treat something that we're developing a treatment for that's a public health issue? Why would we treat it differently?
Mm-hmm. Mm-hmm. So, I mean, they were able to, there were open hearings, there was a lot of dialogue and discussion, and ultimately this was allowed to go forward. And I think, it's again, as far as I'm aware of, it's the only program of its kind in the country. I think there are going to be a lot of eyes on it. And the team, the NYC START teams, are working really hard to try to help the young people who give their consent to participate.
Next up, we have Suparno Mitra and Sanya Virani with a column on the implementation of marijuana legalization in New York, and then an accompanying commentary by Allison Robertson and Marvin Schwartz titled Thinking Carefully About Marijuana Legalization, Public Health Considerations for State Policymakers.
Right, yeah. So the first article is in the State Mental Health Policy column, which Marvin Schwartz edits. And when he got this article and brought it to publication, he was interested in adding to the dialogue. So we have these two really neat paired pieces in the journal.
Yeah, and when I saw these come up, I had actually just been asked in my administrative job about some issues around medical marijuana prescribing, and then also my clinical work with a couple of patients had just been talking a little bit more about marijuana and thinking about the context of both medical marijuana and the legalization of marijuana across the country and the potential legalization in New York State. And so I thought these were very timely just for issues that had come up for me, and I think that that's a kind of a hot topic. Yeah. It's gaining more and more traction.
It just occurred to me that our first two discussions are on something in New York City and state. We got to really watch this, Josh.
All right.
Everybody's going to think all we care about is New York State.
It also, again, it takes a village, so we need a lot of geographic variety in the articles that are submitted to the journal. And not to blame anybody else, we'll take some responsibility here as well. But we are very New York centric today. So in 2018, just to give people some context, the governor of New York asked the New York Department of Health about the potential impact of marijuana legalization in New York State. And they came back with this recommendation that felt like the benefits of legalization outweighed the harms. And Mitra and Virani's article or column is kind of laying out the current landscape in New York State and some of the issues that went into that. Mm-hmm. So right now in New York State, marijuana is illegal unless you have a medical marijuana certificate from a medical provider. And there's a specific list of diagnoses that can qualify you for medical marijuana that include things like cancer, HIV. I think there's like 12 or 13.
Yeah, chronic pain, right?
And PTSD are probably the ones that some of the mental health providers are most familiar with. But otherwise, if you don't have a certificate from a medical provider for medical marijuana, it's illegal.
Yeah, and it's just, again, this may be overly simple for our listeners, but again, it's just important to distinguish medical marijuana from recreational marijuana.
So Mitra and Virani lay out some of the arguments that are in favor of legalization. So this includes potential reduction in opioid-related deaths for people who might turn to marijuana instead of an opioid for management of pain, a decreased criminal justice burden, better regulated and safer supply of marijuana, revenue windfalls from taxes, and also decreased barriers to research into the potential health benefits of cannabis.
This whole issue of revenue windfalls just makes me feel a little uncomfortable. And I know it's a big issue, but making money from marijuana just doesn't seem like a good reason to do it.
Well, I guess the argument would be like tobacco, for example, right? Like if we have taxes on tobacco, then we can reinvest that money into public health.
Right. Okay. Well, and the commerce is going to happen anyway, so they might as well, the government might as well take its cut.
I think that's the idea, is that right now none of that money is going into like
it's all
research.
Profit. It's all profit from the people who are selling it.
On the black market.
All right. Okay.
And then I think the other just really important thing to mention that Mitra and Varani also highlight is that drug criminalization in general has had a disproportionate effect on people of color. Just for a very striking statistic, as an example, 90% of people who were arrested for drug-related offenses in New York State in 2017 were black or Hispanic.
Yeah.
That's really staggering.
Yeah.
So by 2019, Governor Cuomo had come up with a plan for marijuana legalization. And the plan had a number of facets, like creating a regulatory and oversight office, plan for review of prior marijuana convictions, expungement of prior felonies, ways to track information, consumer protections, and also ways to deal with underage use. And then the finances of everything, which you're particularly concerned with, they're going to look into that through a feasibility study. So the paper also highlights a couple of the potential negative effects of legalization, like child and adolescent accidental ingestions, which apparently have gone up in some other states, increase in motor vehicle accidents, direct negative medical effects like lung disease and lung cancer, increased incidence of psychosis, and then the general cognitive effects on the drug at sort of a wider scale.
You realize just how you have to dig beneath the layers and layers of issues that have to be addressed in order to do this in a way to minimize the risks and maximize the benefits. Very complicated.
Yes. And so Mitra and Varani wrap up with a number of issues that any eventual plan to legalize marijuana would have to address. So they suggest surveys, market research, and also really highlight the challenge in reconciling state and federal laws.
Yeah, right. So with the federal laws, essentially marijuana is still being illegal.
Yeah, so you've got conflict between the two. So in the commentary that accompanies the piece, Allison Robertson and Marvin Schwartz, they're...
So wait, I just want to interrupt you for a second. Like all these detailed issues, it's this. What's so cool about this column is that it summarizes the challenge very well, and so you're not reading a 500-page tome.
No, it's like in 5 pages.
Yeah. So it's really nice to kind of get a nice, clean, concise synthesis of the issues in.
Yeah, and it's nice to have two kind of perspectives on it as well.
Yeah.
They're both complementary.
Yeah.
So in the commentary piece, I would say they're lending some additional notes of caution to the column. So they're pointing to the same potential negative health impacts, and they're really thinking about increased public health surveillance on things like motor vehicle accidents, DUIs, hospitalizations, and other negative outcomes. So they also, there's other states that have legalized marijuana, and so they're pointing particularly to Colorado's strategy around marijuana legalization. And there are 3 prongs to that strategy. The first is assessment, which include things like surveys and analyzing records. The second is policy development, and that's things like taxation, like when you're selling, like the hours that you're allowed to sell, how you license this, how things can be marketed.
Yeah.
And then
packaging requirements, and sort of the marketing, the issue of how do we protect children, right? In terms of marketing and packaging.
Yeah, I mean, I was in California recently, and this won't be a surprise to anybody who's been to California. But the billboards for cannabis dispensaries I hadn't been there for a couple of years, and they just popped up everywhere. It was like every other billboard was about a cannabis dispensary. So, the papers really make you realize that all of these are decisions that were made on a government level about what's allowed and what isn't allowed. And what
was your view of these billboards? Were they? It
was from the highway.
Thank you very much, Josh. That's what I meant to you.
Very concrete on this Memorial Day weekend. It was mostly just surprising to me, coming from a time when that would just have been like totally unthinkable to when it's just so, and I don't know, it was also this is something that's been happening for so long, and just marijuana use and is so ubiquitous in a lot of ways.
So let me ask you, was your impression, and obviously you just had a fleeting view of it, did they look like they were more targeted to adults? Did they look fun? What was your sort of emotional response to the billboards?
They were really kind of slick and well done and a little bit minimal. And I think they were targeted to adults, but in a sort of like like hipster kind of way that kind of really appealed.
I wouldn't know about hipster, but you might.
I'm on the edge of knowing about hipster, just to be. I'll take that as a compliment, but. And it also makes you really think about tobacco marketing and alcohol marketing and kind of what's allowed and what isn't and what the potential harmful effects were. So just getting back to Colorado, 3 prongs of marijuana legalization were assessment, policy development, which just talked about it, and then the third is assurance, which is really enforcing all of the policies and regulations. So, and as we've mentioned, I think the other thing that Robertson and Schwartz really raise is the potential harms of marketing to children. And,
edibles, specifically they discussed edibles and sort of how that could really go wrong if candy and gummy bears.
Right. We're thinking about tobacco marketing to children, but these are actual like children's candies that are right. So like you said, it's a very complex issue. It's a very interesting issue, and it does sort of like make you think about your own personal views towards things and how that might be different from your clinical views towards things, which also might be a little bit different from your policy views towards things. So it's a nice couple of it's a good 6 pages to help wrap your head around that.
And just one additional point before we close on this. Mary Brunette has a nice open forum in the last year or so in which she talks about the impact and the worries that the availability of medical marijuana and clearly also recreational marijuana might have for people with psychotic disorders as really a specific subgroup of interest to us in the mental health field, and worries that we have about how the availability of marijuana could make the lives of our patients somewhat more challenging. And I mean, obviously, I have had patients, we've all had patients who really feel that marijuana helps them as well. But there is a specific worry in the case of the development of psychosis and the perpetuation of psychosis. So we have to really, whatever our views are, I think we as a field, and this really includes all providers and friends and family and advocates, to just watch this and monitor this and really push for surveillance so that
we know what's happening.
Right.
Last up, we have Rajiv Ramchand on increases in demand for crisis and other suicide prevention services after a celebrity suicide. So I think, as a lot of our listeners know, suicide has been described and been documented as socially contagious. So that when there's a high-profile suicide, rates of suicide tend to go up.
And it's also, that phenomenon has led to the importance of, the press really having certain guidelines for how suicide is reported. And, there's a really a body of knowledge about this notion of contagion that's quite compelling.
And about how to talk about it, what you should say, what resources you should include, ways to not glorify it or make it more socially contagious than it already is. But on the other hand, when there is a really high-profile suicide, sometimes the cat seems like it's out of the bag.
Yeah.
And,
I mean, there's when you have, it's sort of like celebrity trumps.
Yeah.
Trumps.
Yeah.
Celebrity it's very hard to control.
Yeah.
And so, the celebrity suicide would be one of those really potentially dangerous situations for, from a public health perspective.
And so this article is trying to assess both that effect and also to see whether calls to suicide crisis line also increase during these episodes when there's a celebrity suicide. And they're looking specifically at the time surrounding Robin Williams' suicide in 2014, which was via strangulation. And so what they did is they wanted to see first if there were excess suicides that could be linked to his death. So they're looking at suicide rates in general and suicide rates via strangulation in the 30 days and 30 days after his death, not just in 2014, but to get sort of a baseline, also in 2012 and 2013.
Yeah, which would more or less be the control conditions given, sort of control conditions.
Yes, so I know that you're upset that we've included 0 randomized controls trials, so you're really grasping for a control group.
Right. I mean, look, the world is filled with experiments that for which we have no controls, and so we do our best.
So The other part of their study is also really looking at whether crisis calls go up, whether people are seeking to contact in this case, the National Suicide Prevention Line. And they're also looking to see if volume from websites that have information on suicide prevention, if traffic increases to those websites. So here's what they found. In the 30 days before and after the date of Robin Williams' suicide, but in the years before,
2012 and 2013,
the daily rate of suicide by strangulation was about 30 per day. So across the country. So in 2014, in the 30 days before Robin Williams' suicide, that was around the case. So it seems like the baseline rate of suicide via strangulation is about 30 per day. But in the 30 days after Robin Williams' suicide, the number jumped to 47, which was statistically significant difference. When they look at the overall rates of suicide, they did sort of a similar thing, and that rate jumped from a baseline of around 115 to 147 in the month that was in the actual month after the suicide. So the second part of their study is about information seeking and calls to crisis lines. And what they found is that the calls to the National Suicide Prevention Line increased by 300% on the day after the suicide. And then they level off after 2 weeks or so, but to a baseline that was higher than prior to the suicide. So here's, I think, the most interesting and somewhat disturbing statistic from the study is that on the day after Robin Williams' suicide, only 57% of those calls were answered.
And so that really speaks to this issue of do we have capacity to meet the demand, the increased demand after this celebrity suicide? And I think we would have to conclude that we don't.
Yeah, and I think it challenges us to think about what the crisis services are, and they also mention about how it has downstream effects to where these lines are referring people to, hospital emergency departments, police departments, that there has to be some sort of flexible response, or else we're really missing an opportunity to help people when there's the most need.
Right, and I think with a celebrity suicide, part of perhaps the point that the article's making is that it's not a secret. In other words, it's out there and it's somewhat predictable. And so that if we could have a way to, in a planful way, respond to unpredicted events, right? But events which we can predict what the after effects will be.
Yeah, and I think just more broadly, it's, we're in a time when we're kind of inundated with data that's going to give us increasingly kind of fine-grained opportunities to understand public health and epidemiology around some of our disorders, and it's going to have implications for the services we can provide. And so the question is, can our systems be flexible enough to actually accommodate the data? So here's a very clear example where there needs to be some flexibility in the system, and can we rethink how we're providing services that we can increase capacity as it's needed?
Now, I know, Josh, there was another data point from this article that you also found to be somewhat troubling.
What was it?
Well, it was the fact that in the prior week, only 73% of the calls were answered. So even on a good day, prior to the celebrity suicide, not all the calls were being answered.
I was so disturbed that I just put it right out of my mind. But that is like a real question for me. Like, what is going on in general with when our and I don't think I know, and I'm not sure the authors know about, are these dropped calls, are these technical issues, or but I would think that number would be like
closer to 100.
Closer to 100 than 73%. Yeah. So I think there's both the issue of, can we flex our services, but can we also make them beef them up so that people are getting the help that they need?
Yeah. Well, unfortunately, we've had now several articles that we've discussed on suicide, and we're still in a terrible crisis in this country. Well, it's hard to end on that note, but that is our reality. That concludes our podcast for this month. We invite you to visit our website, ps.psychiatryonline.org, to read the articles we discussed in this episode, as well as other great research and essays. We remind you also to check out the Editor's Choice collections. We are have released one on homelessness and are about to release another one on disparities. They're really fun, and I hope that you make use of them. We welcome your feedback about the podcast. Please email us at psjournal@psych.org. I'm Lisa Dixon.
I'm Josh Berezin.
Thanks for listening. We'll talk to you next time.
Bye-bye.